I was gonna have this as an open forum as to like a question answer discussion. I can give you a talk about a certain subject that you may want to hear about. But one thing that really dovetails what you just heard about cardiac, and I don't like the term rehabilitation, is really cardiac fitness or just life fitness, because these are life skills that this program teaches you about just being physically fit to improve your vascular health. And one really important thing is just being fit. And what does that mean? Yes.
It might is open. We don't like to hear what you have to say.
Is this better?
Yeah.
Is that better? Okay, good. So what I was saying before is that what we're trying to emphasize, especially in the world of cardiology, is fitness. And it's not only physical fitness, but it's emotional fitness and mental fitness and social fitness. And what does fitness really mean is just getting out and doing a walking program. And when they have the term cardiac rehabilitation, I don't like the term rehabilitation. It's more a cardiac fitness program that strengthens your mind and soul and physical body. And that's really, if you look at the emphasis of healthcare, that's where we're really trying to direct not only the physical part of the of your body, but also your soul and emotional part. And that's broken down to nutrition, exercise, and just being socially fit too, getting out and like a nice night, like talking about pretty good subjects. And the medications that we recommend are just kind of icing on the cake, but really the most important thing is what we can do together to empower that person that comes to see us to take control over their own health. And one thing that I try to do is to work out a fitness program for that person. And it's not like one size fits all. Everyone's different as to what they can do as a fitness program. And so it could be just a walking program for 30 to 40 minutes a day at a low pace. Or it could be on a bicycle or a recumbent bicycle, water aerobics, or whatever you like to do. If you can only do it for 10 minutes, that's better than nothing at all. But once you start to get your endurance up, so you do 10 minutes one week, the next week it's 12 minutes, the next week it's 14 minutes, up to about 30 to 40 minutes a day per week. And you'd be surprised that you'll feel better, and your blood pressure gets better. If you're diabetic, your diabetes gets better. If you have high cholesterol, that gets better. If you have sleep apnea, that gets better. Even rhythm problems of the heart, atrial fibrillation incidence, atrial fibrillation is a lot less for people who are physically fit. So that's just one component of it all. That's kind of the medications that are used. But does anybody have questions about what exercise program would be appropriate for them? Because there's a lot of misnomers out in the community as to what you should do, what you shouldn't do. Like people say, well, I should do my heart rate, I should watch my heart rate. So what we really recommend is, at least when you're exercising, when you can't carry on a conversation, that's when you're really working hard. It's not your heart rate. Yes?
It's very hard to hear back here.
Okay.
I don't know if that thing is working back here.
It doesn't sound like
Yeah, it doesn't sound like it is. I don't think
I'll
it's
talk louder. Is that better?
yes.
Yeah.
Sorry, we're having a little microphone issue. We can't, it won't, it's either you have Dr. Grady like this, or...
I'm going to talk like this. So what we're talking about, is that better? Is a fitness program. So we're trying to, and it really is an open forum as to any questions you have. It could be a medication question, a procedure question, nutrition, blood pressure, whatever it is. And if I'll just try to field the question. But one thing that I like to talk about is what we can do independent of medications. So one thing is a fitness program. And I don't really use exercise because sometimes exercise gets a bad connotation. So it's just being physically fit. And it can just start off as a walking program for 5 minutes or whatever, how long you can do it. It's not the intensity what's important, is the duration and the frequency. So the duration goal would be between 30 and 40 minutes a day. And then frequency, we try to do that every day of the week. And it could be whatever you like to do. It could be swimming, it could be water aerobics, it could be riding a recumbent bicycle. Pretty people get lightheaded or fall frequently. If they're riding a bicycle on the ground, it strengthens their lower extremities, their coordination gets better. It actually improves the sympathetic tone, the blood vessel tone, so you get more blood returning to
the right side of the heart, and people get less lightheaded. And that's a really good form to treat lightheadedness, is riding on this bike that's, lying down. You can watch TV, whatever you want to do. But these are all physical fitness things that can help out in all avenues in cardiovascular health. And I mentioned diabetes, high cholesterol, sleep apnea, hypertension, rhythm problems. It also improves the elasticity of the blood vessels, so the blood vessels dilate better, they're less sticky, so plaque formation is less frequent, and then the permeability of the blood vessel also gets less permeable, because how arteriosclerosis first begins is the blood vessel wall becomes leaky, and cells adhere to the blood vessel wall, and they get into the blood vessel wall, and then that's how you have plaque formation. So exercise is really good for that. There's also a form of heart failure called heart failure with preserved ejection fraction, or it's diastolic heart dysfunction. And as we get older, for all of us, myself included, the heart changes anatomically, so the heart gets stiffer. It loses the elasticity, or the compliance of the heart gets worse and worse and worse. So the heart it's hard to fill the heart with blood. Blood can get out of the heart really easily. It's like a stiff balloon. It's hard to inflate that balloon, but the air gets right out. And all the medications that we've studied for this haven't really been shown to be helpful, but exercise, and just talking walking, helps to reverse that process or slow it down. And the symptom of this diastolic heart dysfunction that we see all the time is shortness of breath. Particularly if you got to climb stairs or an incline or a hill, you get short of breath. So by doing this exercise program or this fitness program, that helps with the compliance of the heart and elasticity of the heart. So that's little things that you can do, or we can all do together. Yes?
But doesn't the extra pressure of exercising on the veins and whatnot cause more damage to the veins?
No. So you're talking about, so when we exercise, your blood pressure goes up, and that's true. But the top number goes up, the bottom number, the diastolic blood pressure, actually should go down or stays the same. And that's the compliance or elasticity of blood vessels, and that's what we're trying to preserve. So people who don't exercise, both numbers go up. People who do exercise, for the most part, the bottom number stays the same or goes down. The top number is the impedance, or how hard the heart is contracting against the pressure. And that does go up because you're exercising. And that'd be a normal response. You want that to happen. That's how strong the heart is. The bottom number is the elastic recoil of the blood vessels, so the blood vessels are compliant. So the bottom number is high in your blood pressure. That means you have stiff arteries. And that's when you do damage, because it's like you have these stiff pipes that don't expand, and that you can't get enough blood flow to your body when you're exercising. And so it's a hardening of the arteries, so to speak. And it happens to all of us as we get older. And how you can prevent that or slow it down is by just a fitness program. And then nutrition. So the DASH diet's a really good diet to adhere to. And again, diet's not a really good term, because when I think with diets, it's short term. If I want to diet for a few weeks and I'll lose the weight or whatever your goal is, well, it really should be a nutritional program for the rest of your life. And special occasions, you can be a little liberal with your diet, like anniversaries or certain holidays or birthdays, but other days you have to be consistent about adhering to a really good, healthy diet. And so that's lots of fruits and vegetables. Berries are really good because they have a lot of flavonoids, antioxidants, so cranberries, blueberries, raspberries, strawberries, whatever berry you like, they're all good. Apples, and try to limit your intake of the carbohydrates. That's the processed foods, breads, pasta, rice, even pretzels. So people say pretzels don't have cholesterol, but all it is carbohydrate. It just goes into sugar, and then you get a lot of carbohydrate, you change it to diabetes, or high triglycerides go way up, and that's not good. And what happens if you have high glucose or high sugar, that causes your blood vessels to be more stickier and more leaky, which we're trying to prevent. So these are little things that really, if you think about it, if you're consistent, go a long way. And this is independent of medications, and it's working together. So like a walking program, like wall walking is great. Going to the Great Northern Mall, going to Walmart here, and just walking there with your friends. And so we're going to meet every day at 9 o'clock, or have a routine. I think routines are good. You get in that routine. Because I have a routine every weekend. That's what I do with my kids. I go to the Y, and we go, and we exercise. They do their thing, I do my thing for an hour, and, you know, I wish I could do it on the weekdays, but I don't, but that's our routine. So getting into routine and sticking with it. The hardest thing, I think, for even myself included, is that when you start a program like that, people tend to stop after a week or two because they say, I can't do this anymore, I get bored. But if you stick with it for about 4 to 6 weeks, it's really, you start to like it. And, you know, for me, I just start kind of zone out. I just don't think of anything. I'm just kind of like you're at one with everything. It sounds stupid, but you know, your blood pressure goes down, your heart rate goes down when you're at rest. But it's not going to happen right away. But sticking with it. Or I know somebody here loves basketball, and that's you know, you do that because it's a good aerobic fitness. A lot of resistance to that too, but it's really good. You're out there sweating away. You don't even think of things. And so, but doesn't have basketball. We could just walk it. Yes.
Going back to what you said about if the bottom number is high when you exercise, then you know it's hardening of the arteries.
Well, it means that the compliance of blood vessels is not very good.
What number would you consider high to
90.
90 would be the high?
And above 90, 80.
And the next, and if you're on high blood pressure medication, will the high blood pressure keep the top number down?
Well, you should keep both numbers down.
It will
But
keep, the high blood pressure medication will keep both numbers down when you exercise?
Right. There's certain medications that are better at lowering the bottom number than others. And so, but if you look at the most effective blood pressure medications in people who are in term older, so and here's a definition. What is the definition of being old? It really
Somebody
is
older than you.
you have to use, because there's a difference between being old and frail. Okay? Frail is someone who's not fit. And that's bad. That's a bad kind, because it means that that person's at high risk for having something happen. It could be falling, fracturing hip. So the definition of old, the reason why I have to use something, I use 65 because that's when most people retire. But other people use 70, other people use 60, but frailty, you could have someone who's 40 years old who is frail. They're not fit. And then you have someone who's 80 who's old but is fit. Another analogy is someone could be overweight but they're fit. That person has a much better prognosis than someone's thin who is not fit. Or there's a paradox in cardiology. People who are heavy after an MI have a better prognosis than people who have normal body weight after MI. And the reason for that is we think it's not because the heaviness is a good thing. It's that person who was heavy probably would not have had the heart attack if they weren't heavy. The person who was thin and not heavy, they were going to have the heart attack because of their genetics. So it's being fit that counts. But to answer your question, your blood pressure medications should lower both. But some are targeted, like the calcium channel blockers are about lowering the bottom number. And people who are older, the calcium channel blockers or thiazide are the most effective drugs to lower someone's blood pressure. Not ACE inhibitors or ARBs or beta blockers. I'm sorry, I'm kidding. But the calcium channel blockers and the thiazide. So there's certain medications that really are preferred that improve someone's, and I don't say lower someone's blood pressure. It's really improving the health of your blood vessels. Because that's what we're all about. We're trying to, it's not really lowering blood pressure, it's how do we improve someone's vascular health, cardiovascular health, to prevent medical problems in the future, to improve the quality of your lives and my life with good quality of life. And really, the cornerstones are nutrition, exercise, weight management, and try to avoid things that are going to hurt us. And not in any way with drugs or cigarettes or like alcohol. Yes?
I was waiting for you to mention that word, genetics. And that's the essence of my question. But first, I wanted to thank you for your program and give you some feedback. Last year, I asked you the question about shoveling snow. I'm a caregiver for an 85-year-old, and your answer seemed to emphasize, just push the snow and do it lightly. Well, that changed everything, because when we went back to our heart doctor, I rephrased the question, and he said, oh, pushing snow, light snow is great. And it really changed her. It encouraged her to get out and get air, and then that leads to more exercise. So it really, just the answer to the way you answered that question really was a tremendous change for the the person I'm doing a caregiver for. And so now, let me ask what I really had in my mind was genetics.
Okay.
And I'm from a family that had a history of heart issues. How will I know? Is there any clue that I can know that if I'm affected and have the bad genetics? Do we so advanced yet? Is there a gene that we can signal that we have that we have a propensity to heart issue? Is there some pattern of a bradycardia, for example, maybe that would be a hint that I'm going to have problems down the line?
Well, okay, so if you have a family history of premature coronary disease, the definition of that, if you have a first-degree male relative that's having been prior to the age of 55, or first-degree female prior to the age of 65, that's the definition of premature coronary disease or having a blocked artery in an early age.
Mm-hmm.
There's a lot of talking soft again. So that's the definition. So is a genetic screen? There's not genetic screening yet because heart disease is polygenetic, meaning there's more than one gene that predisposes to heart disease. It's like hypertension. There's more than 10 genes that predispose to hypertension. But it doubles your risk. So someone in your family does have a history of premature coronary disease, you're twice as more likely to have an event than the person that doesn't have that. So clues to clue you in would be the classic, you're out there shoveling snow or raking leaves or even vacuuming and you get this heaviness in your chest and you stop and it goes away gradually after about 10 minutes. And then you go back and do that again as a pattern, it's gonna come back. Unfortunately, one of my patients with heart disease, he is 72 years old, had flu-like symptoms, he didn't call me, and he died of a heart attack because he had flu-like symptoms. The Supreme Court Justice, Antonin Scalia, he died of heart disease, and he went to his doctor twice the week before he passed away, complaining that he just didn't feel well, he had like the flu. I don't know the autopsy results, but I think he died of heart disease, and he didn't really, he's a heavy-set guy who smoked. But if you look at, I looked at him, I said, he probably had a heart attack, but I didn't know he had gone to his doctor until I read that in the paper, complaining he just didn't feel well. So just not feeling like you feel achy and you feel fatigued, or just being tired and a lesser workload. So someone came to see me today, I hadn't seen him for a year, and he said, geez, I can still cut wood, but I can't cut as much before getting tired or getting short of breath. Those are all clues. Or you're just tiring out with less exertion, you're short of breath, like climbing hills. Maybe that's that diastolic heart dysfunction we talked about, but maybe you're not getting enough blood flow to your heart. Or you wake up in the middle of the night with chest pressure, that's another clue. But there's a pattern too, it's not a one and done deal.
If it's genetic, can those things happen very early in life? What's the earliest you've seen a heart patient and
So
said,
if
he's genetic or she's genetic?
So if you look at familiar hypercholesterolemia, if you almost homozygotes don't live, that means the cholesterol is super duper high. They have genes that you don't metabolize the cholesterol appropriately, so their cholesterol is extremely high. We're talking about 900. You have kids, like 13-year-olds having heart attacks, and so there are new drugs for that. There's also, you can transplant their liver because that's where the cholesterol is made. But that's a particular gene. That's one gene. But most people, when they have premature coronary disease, talk about 30s and 40s. You can see it very early on in life. So things people can do when they're children, adolescents, young adults, is exercise, nutrition, not smoke cigarettes, take good care of yourself, try not to get too heavy. And if people do all those things, most people don't require medications. Some people do because their blood pressure is high. But the reason why we lower the blood pressure is really to improve someone's vascular health. And blood pressure is like a hammer hitting the organs. So the higher the blood pressure, the harder the hammer is hitting your brain and kidneys. So you want to lower that so that you have less trauma to your blood vessels, to your organs. And that's the goal. So exercise can lower your blood pressure by about 10 millimeters of mercury. That's better than any drug that's out there. So salt restriction is controversial now, but my take-home message is be realistic, but 3 to 4 grams of salt per day or sodium. So try to avoid the processed foods because a lot of hidden salt, frozen foods, canned foods, they have a lot of sodium or salt in them. So watch that. And then, again, having like the DASH diet or the South Beach diet, Mediterranean diet, lots of fruits and vegetables, lots of protein, so lean cuts of beef or pork, fish that's not fried, skinless poultry. Again, try to avoid the carbohydrates. If your blood pressure's high, I think you may have sleep apnea because it goes hand in hand with blood pressure. But we can map the human genome, but it's very expensive to do so. But 10 years from now, you're going to probably be able to map someone's genome and then target therapies based upon their genome, because not everyone responds to drugs similarly. Some people have a good response, some people say, well, geez, I really respond well to that drug. Someone doesn't respond as well to that drug. That's all going to change, so you can actually map someone's genome and target your therapy based upon their genes. That's not being done right now. We have the technology to do it, but it's just too expensive to do it. 10 years from now, you betcha, that's what they'll be doing. And they'll be able to tell you, geez, your risk of having something bad happen to you cardiovascular-wise is pretty high. So what do? You take really good care of yourself. Because most heart attacks in young people, there's no warning. There's two types of heart attacks. One usually occurs in young people where you have a plaque that's like 10%. And you have stable plaques, which are calcified. So it's calcium business. They say, oh, you have calcium on your CT scan. Well, that may be a good thing, because usually calcium signifies that plaque's stable. And then unstable plaques that have no calcium, maybe just 10%. If it becomes unstable, underneath you have this cap, and then beneath the cap is cholesterol. So if that cap becomes unstable and ruptures, and the cholesterol's exposed to your bloodstream, you get a blood clot. And what's 10% becomes 100% in less than a second. No warning at all. And that's how most heart attacks in young people occur. And even people who take really good care of themselves can happen. And then later on, if that plaque gets progressively larger and larger and larger, symptoms really don't start until the plaque's more than 60%. Then you start to get the chest pain or the shortness of breath. And those are clues that you have a plaque, that you could have a plaque that's more than 60%. And you can go seek help, but then that's enough for a heart attack where you don't get enough blood flow to the heart because of this blockage, and you'll have the warning though there. That's a more common heart attack. Yes?
Getting back to the low blood pressure, what is too low and what is the range for the good low?
Okay, so you're right, you don't want your blood pressure too low, because if your blood pressure is too low, you get lightheaded, you'll get decreased blood flow to your kidneys don't work as well as they could. So for the bottom number, 60. And the reason why I say 60 is because what drives the blood flow to the heart is that bottom number. So when the heart's getting its own blood supply, it's that bottom number that's driving the blood to the heart and through the coronary arteries. So if you drop that pressure, you're dropping that perfusion pressure to the heart. So you don't want to get the blood pressure less than 60, the bottom number. Sometimes it's 58, but we use 60. The top number is different. The top number usually I don't really care too much about. If someone tells me they're lightheaded, then I say, okay, your blood pressure may be too low. But I know people whose blood pressure is 90 over 60 and they feel fine. I'm fine with that. What I do also measure the kidney function to make sure the kidneys are doing okay. And it's stable. I know that there's enough blood flow getting to the kidneys. Because low blood pressure is good. That means the heart's working less. And people with a weak heart, they're going to have a low blood pressure to begin with because the heart's weak, so it can't pump the blood that well. Or if if someone's got like a leaky mitral valve, you want the blood pressure, the top number low, because the lower that number, the top number, the more the blood's going to go in the right direction rather than the wrong direction. You see what I'm saying? So when the heart contracts, that mitral valve closes. So blood doesn't go back in the opposite direction. It goes out to the aorta. So you want the pressure in the aorta low, so it doesn't go back here. It's like a pop-off valve. You want the blood to go in the right direction. So 60, it's really the bottom number that we're concerned about. 60 is the cutoff point. The top number, it's based upon someone's symptoms. Another analogy is, this is why one doesn't fit all. If someone's got blocked arteries here, carotid arteries, they're going to need a little bit higher pressure to get past these blockages. So we don't want to lower the pressure too much in people with blocked arteries up here. We don't want the blocked arteries to begin with, but the reality is someone have like a 60% blockage here. We don't want to lower the pressure too much because it needs a little bit higher pressure to get past the blockage. So everyone's a little bit different as to what they come with. factors, but, you know, the ideal blood pressure for people in this room is about 130/80. And, so that's, you know, it's a recent trial looking at, you know, they changed the goals 2 years ago. They liberalized the goals. They said, well, we'll now take a higher blood pressure, 150/90. And I disagreed with that. A lot of cardiologists did too. There's a recent trial called the Spirit trial, looking at lowering blood pressure, and actually that was wrong. We want the blood pressure like 130/80 for the majority of people. So if that's what your blood pressure goal is, that's really what you want to be at. And again, so the cornerstones of blood pressure lowering, again, is exercise or fitness. So I try to say fitness because exercise, you don't have to do a running, or you're just walking, being active. Instead of, if you can, instead of walking the flight of stairs rather than taking the elevator, if you can do that. Simple tricks like that, and they go a long ways, being consistent with that, or being active. And then, you should all be commended. You're out, it's a Tuesday night, and you're out listening to me. But you're out, you're making the effort to come here. That's a good thing, because it's a social thing too, where you can interact and talk and exchange ideas. So that's really important too, someone's mental health, or reading, or doing, card games are great. That's another component where you keep your mind sharp, and you're out there, talking with other people. But those are really cornerstones of medicine. Yes?
I wanted to ask a question about stents, the purpose of them, and also, can you lower your cholesterol in your arteries with your diet?
Yeah, well, so stents were developed in the 1990s, early 1990s, and the technology's really expanded. If you can think of a slinky, okay? So it's a slinky that goes in the lumen of the blood vessel, so it prevents elastic recoil of the artery, so it doesn't collapse on itself. Okay, so it kind of expands a little bit, and then your blood vessel lining, okay, called the endothelium, will coat the stent. It takes about 6 weeks for that stent to be coated. So your own blood vessel lining will coat that with good cells. Sometimes though, you have overgrowth, and that stent can, we call it in-stent restenosis, where it gets narrow because you have too much cell growth. But these new stents called drug-eluting stents, okay, there's a lot of stents with different drugs that prevent the cell growth from being too aggressive. So you have the stent, which is usually cobalt chromium metal, and it doesn't, the reason why I use that is it usually doesn't cause an allergy. So it's almost hypoallergenic. And then there's a polymer platform, and if it's a drugging stent, the drug is impregnated in this polymer. And then now there's bioabsorbable stents with a stent, actually it's just absorbed in the blood vessel wall. They'll probably be approved in the United States in about a few months. It's approved in Europe right now. But so stent technology is really growing, because the whole goal is that we want the stent actually to go away, and so we don't want to take, because once it's deployed, you can't take it out. You can take it out surgically, but you can't take it out. And then yes, you can actually lower your cholesterol a lot, by about 25% through your nutrition. Now, if you have a genetic defect in cholesterol metabolism, that's a different story. That's hard to do. But it's just avoiding fried foods, avoiding cheeses, marbled meats. Those are things that have a lot of cholesterol. But if your cholesterol remains high, it's very high, you may want to get screening, genetic screening, to see if you do have a metabolic abnormality in cholesterol metabolism. But it's really, again, what you're eating. And the thing is, you don't want to skip meals either. That's a big mistake. Breakfast, lunch, and dinner. Try not to eat in between meals. But yeah, you can lower your cholesterol. So again, there are 3 diets, and you can Google them. The DASH diet's really good. The South Beach diet, or the Mediterranean diet. Those are all really good diet programs, and they have a lot of good nutrients, and they taste okay too. On a birthday, it's fine to have a birthday cake or ice cream, or Christmas, or the holidays or anniversaries, or a piece of steak every once in a while. But really, it's like fish, skinless poultry, any cuts of beef and pork. Try to avoid like the waffles, the pancakes, the French toast, bacon, sausage. Those are really fatty foods that really don't have a lot of nutritional value.
but so good tasting.
You know, if you don't have them, after a while, you don't miss them.
That's true.
You don't.
Yeah.
You don't, I mean, and I'm not saying you can't have them, but you're much better off with having scrambled eggs and maybe one toast, than waffles or the other stuff. So, yeah,
We talk about beans and nuts as a form of protein,
you can do,
rather than the marbleized meats.
well, beans have some protein, nuts don't have that much protein, they have good fat, like, but the good, the four nuts that are good, the other nuts aren't so good, would be walnuts, almonds, which are very common, and the other two are filberts and hazelnuts, which are also common. Those are the four nuts that are good. The problem with nuts are, and I encourage you to try like a fistful in the afternoon, but a lot of them, like a can, they have a lot of calories, so they're punched with nutrition, but also with calories. So you gotta watch the caloric intake. Beans, they have some protein, but if you're vegan, that's hard to get the protein, a lot of the protein, but you can get soy or whey, they have some protein, or tofu, things like that could give you some
Kidney
protein.
beans,
They have-
garbanzo
Yeah,
beans.
they have some protein. So, but those are all good too for you. So those are all alternatives too. And these are things that, these are outside of the medications that we give to, prescribe. But these are things that can really, these are really the pillars or the basement of health. Yes,
What were you saying about seafood?
seafood's good. Yeah, they have some cholesterol, but usually good cholesterol. And that's what you, like if you have shrimp scampi, it's some cheese and butter, so.
That's pushing it.
So, and seafood for me kills me, I'm allergic to shellfish. So, but fish is really good, I mean, fish, it's all what you, but shrimp cocktail is fine. Lobster's good, but you dip it in butter, it's not so good.
Deep fried.
Yeah, so it's well what you, it's what you, what you're cooking it in, and the condiments that you have with it too. Yes,
Can I ask about butter and margarine? That's one thing.
don't buy margarine.
Don't buy it?
You don't have to ask anything else, just don't buy it.
Even the Brown and Brummel yogurt?
Yogurt's okay.
No,
Margarine,
it's yogurt margarine.
margarine's not good for you. It's just, you're better off with butter.
Butter?
You're better, a little butter or olive oil. I would stay away from margarine. It's not,
What's in margarine typically that's?
it's almost like a synthetic butter, it has trans-esterified fatty acids.
Trans fats?
Trans-esterified.
At one time, they used to say if it melts at room temperature, it's safe and good to eat.
Right, because it's
Doesn't
in your
make a difference,
veins.
it's the same thing. It's the same thing, it doesn't make, it's made up of the same thing. And if you look at it, margarine's, actually margarine is clear, and they use a coloring to color it. It's almost like just, it's not fat, but it's just synthetic fat. And it's more of just, it's a taste, if you're gonna do anything, go natural, go use a butter. And butter's all right, I mean, you still want too much butter. It's all in moderation. But olive oil, oregano, they're better for you, but you're better off, if you want something on your toast, to have a little butter and put some jam on it, or peanut butter, things like that. But the margarine, I would stay with the synthetic stuff. I mean, even the artificial sweeteners, I'm not a big fan of, because you can't get, it's just, I think it's just not healthy. And there's too many preservatives to begin with.
My total cholesterol number is high, but my healthy cholesterol is above the high number, and my bad cholesterol is lower than the low number. So the doctor said she's not concerned about the cholesterol whatsoever.
Yeah,
I have heart issues, but she said because the bad cholesterol is way low and the good cholesterol is way high, then.
That's a good thing. I mean, if you have heart disease, your bad cholesterol goal, the LDL goal would be 70. Alright, so that's where you want that 70 below.
Is that the good or the bad?
That's the bad.
Okay, it's lower than when it comes back on the chart, it comes back low.
That's good. That's good. That's protected. That's really good. And that means that you're doing, whatever you're doing, that's good. So it's, that means when you're good cholesterol, the HDL, the high density lipoprotein, is high, you want it high, and you want the bad, the LDL cholesterol low. You have to also think about that's number. You have to think the quality of the particle, because there's a whole family of HDL particles and LDL particles, and they're all made up of lipids and apoproteins. So aprotein A is good, aprotein B is bad. So your numbers are good, but you want to know what the quality of the particle is too. But if your triglycerides are low, that means your LDL particles not so bad, and HDL particles good. So triglycerides go into it too. So, but that's really good. That's good. Any other questions about? Yes.
Can you talk a little bit about hard work every day and the effect that that has? Some people like to do things and
Right.
keep busy every single day.
Right. It's hard work. Okay, so it's really how someone responds to hard work, or how you respond to stressors in your life. So some people have a lot of stress in life, but they deal with it, or they have strategies that are healthy strategies to deal with that stress or that work. So they can say, okay, I'm working really hard, but I have these strategies so that I can channel the stress in productive ways, in healthy ways. It could be through exercise, it could be through meditation, it could be prayer, it could be a lot of things, whatever works for that individual. Now, if someone's under a lot of stress and they're too stressful, then our body becomes frightened. And when we become frightened, then we release adrenaline. Because we're either gonna run away or we're gonna fight. And adrenaline causes your heart rate to go up. Okay, so you increase heart rate, your heart pounds faster and harder throughout muscles, but also it can cause electrical problems too. We call like rotors. So you want your heart to act as one rotor. When you have a lot of adrenaline, there's a lot of separate rotors going like this, and it can cause people to go into AFib or really bad rhythms. Or it can cause all the arteries of the heart to constrict, and that's called a Takotsubo cardiomyopathy. And what that is that it's a Japanese fishing term. The Japanese fisherman uses fur to catch octopi in. It's like a balloon. And when someone comes to the hospital with this, it looks like they're having a heart attack, and the heart looks like this big urn. And in fact, it's dilated because all the arteries are constricted. There's no blockage, it's just constricted like that. So stress, type A personalities, I don't care. You could be anywhere. It's what that person does to deal with that stress. And that's why this really, what we're trying to promote, particularly in our Oswego Health, is we're a healthcare team. We're all a team, so where there's no outliers. So you're not all working. One person is not. They're working as hard as they can. We have all these teams to help people out to reduce the stress, so that if someone has a lot of stress, they can talk about it. Because how we handle stress that's really the key. Because all of our lives are stressful in some regards. How do we deal with that stress? And I just and I learned this in the military, is that whatever environment you're given, you make the best of it. You could be in a place where in the middle of nowhere, you just say, okay, how do we make the best possibility, not just for Tom Grady, but for everybody who I'm with. No one gets left behind unless it's an extreme case. So we make it better for everybody. And then stress kind of still there, but it's not so bad. Laughter is really important. You gotta kind of make light of things too. It's serious, but you make a laugh, hugging, I know this is really important too. I try to hug patients before they go, because I really do care. Because sometimes things don't work out the way I want them to work out, and it's just the way things end up. But you can still care for somebody. So it's how you deal with that stress. But yes, someone who has a lot of stress and has no good coping mechanisms, that's a recipe for disaster. Because it's going to build up. And you have high blood pressure. That plaque they told you about, that maybe why get a plaque to get unstable, get a lot of stress in someone's life. Then you have turbulent blood flow, and if you have turbulent blood flow, it's like erosion. Like the beach is being eroded, and the waves are because of all the stress in someone's life. It's going to erode that cap, and then you have the visual cap, because that's when a lot of people, when there's a lot of stress, that's what happens. They have a heart attack without any warning. So that's a good point. So stress in someone's life is definitely a risk. It's really, that's why again, the emphasis in healthcare right now, and I can only speak for myself, being a team. So everyone's important. The janitors at that hospital are important, the people who do the food service, the people who clean the bathrooms, the people who, the nurses, the doctors, everybody. Everybody's important. And we're all just equally as important too, because if one partner, one piece doesn't work out, then it's not gonna work out for everybody. So it's really the whole healthcare team, and you're part of it too. And you're here tonight, and you're part of Oswego Health. And you could be mentors for people when you leave here, saying, you know, we gotta take better care of ourselves. I do, everybody. It's just not physical care, it's emotional care and care for one another. Yeah.
You talk about high blood pressure, for people that don't go to the doctors, what blood pressure, devices would you recommend that someone get home to
So,
take?
Yeah,
Is there any specific, I know there's wrist ones and there's
I
pumped
would
up
try to get
ones,
one in right here, they're a little bit more accurate.
the ones that you,
The brachial blood
doing
pressure
things and then you
monitors. Yeah.
pump it up and
Yeah,
listen.
Because as you travel away from your heart, the blood pressure actually goes higher. It goes higher. So your pressure in the ankle should be higher than the pressure in the heart. And we actually use that, called ankle brake indices, to see if someone's got blocked arteries. So OMRON, OMRON, home blood pressure monitoring, that's a good brand. It's OMRON, OMRON. And I would hope that most insurance companies at least cover some of it.
Do you have to order that, or is it?
You can, Wayne's, not all drugstores have this, but Wayne's also has equipment, so they should have it there. And you can acquire your insurance will cover it, some or not. And you can call your
Would you have
doctor.
to have a recommended by the doctor for your insurance to cover it?
Yes, you do. Yeah, but that's easy, just you call over there and say, Mrs. Jones, I'll run blood pressure, break your blood pressure unit, and hopefully your insurance covers it. That's
right side.
both, you need to do both. I always take blood pressure both arms, because it could be different. Shouldn't be different, but it could be. Yes,
To continue on the blood pressure, I normally take my blood pressure medicines in the morning, but mid-afternoon, it went down to 54/43. Now, two questions, what caused that? And then if the blood pressure drops that low, what do we do to bring it back up?
alright, so what causes it? Well, it could, blood pressure is gonna fluctuate, so if you're sick, like say you get the flu, then your blood pressure is gonna go low. Or say you're having diarrhea, or you're nauseous, not eating that well, then your blood pressure is gonna probably tend to be low. Say you missed lunch that day, your blood pressure can be low. So there could be a lot of reasons why your blood pressure is low. If you take all your blood pressure medications together, then I'm not sure what you take, but the pharmacokinetics, it's gonna, when you absorb, how a drug works, first you have to absorb the drug through your GI tract, then it has to be distributed to where it's gonna be worked, then it has to work, and then it's excreted. So it all depends upon the medication you're taking, their half-life, the pharmacokinetics, the bioavailability, or as to where they're distributed. What I usually try to do is you try to tell people if you're on 2 blood pressure medications, take one in the morning, take one in the evening. That way you're not getting everything together, and you're getting everything together, and you may get low blood pressure if you take it all together. There are certain drugs too that can really lower your blood pressure, and I'm not sure what you take,
Well, it's the generics, I can't remember the names.
that's all right. So there are certain
Clopidogrel
clopidogrel.
and metoprolol.
So clopidogrel won't lower your blood pressure. Clopidogrel works on platelets. And metropolol, that shouldn't lower your blood pressure too much.
And losartan, tartrate.
Okay, so you may want to take like the metropolol in the morning, losartan in the evening.
All right.
See how that goes.
Now, if ever that should happen again, that it drops so low, is there anything to do?
Yeah, you sit down, lay down, put your legs up, and drink. You can drink some water.
All right, water, all right.
If you're really lightheaded though, you may want to go to the hospital. But yeah, you lay down, put your legs up, that way you're getting blood to your brain, and then try to drink some water. Yes?
Thank you.
There's an idiom that hard work never hurt anyone. and I wanna know how this guy's live. And I somehow work that somehow in, I work hard every day and I love it and I feel great.
Then you, if you love it and you feel great and you have good outlets, keep on working hard.
Yeah,
As long as you love what you do, you have a passion, you can share that passion with other people, and you can channel the stress of the job in a productive way, that's a good thing. It's the people who bottle it all up, or like, you want to use Wall Street as an example, but there's no outlets for them. That's not good. But and they tend not to like their job. But if you have a passion, I mean, I work hard too, but I have a passion in what I do. I mean, there's certain days that aren't so good, but there are certain days that are better, but, I have a passion because, what makes it worthwhile is you. I mean, I work for you. And I'm not trying to compliment you, but that's why I went to what I went to. It's service to other people. And God gave me a gift, and this is a gift I got. The best way to develop that gift is share with other people. We all have gifts, you probably share it with people. That's what it's all about. That's how, you deal with kind of stressors in life. You're sharing your talents. That, at least for me, God gave it to me. It's up to me to develop those talents, and one way to do it is to share it with you, like tonight. So if you have a passion in what you're doing, that's great. It's just sharing.
I do.
Yes?
Could I ask, what you think about someone who had big 1 or 2 bowls of ice cream every night? It's dangerous for your cholesterol, right? Every single night.
They do it fat-free.
How big are the bowls?
I mean, is there any value in that?
Yes, it tastes good. So, I would think, some people can do that and get away with it. I mean, I try to kind of mix up something. One night you have the ice cream, another night maybe you have yogurt or a cantaloupe or a melon. Because once you start, it's more behavior. It's like you get in these routines. Okay, well, it's time for my ice cream. Maybe you mix it up. Say, I'm gonna have cantaloupe tonight. Because not cantaloupe or watermelon or stuff like that. I mean, it tastes good. And maybe you want to do that. So to answer your question, it's not a healthy thing to do. Because ice cream, it's a treat. So treats are really for special occasions. But at the same time, if someone's really working on you, you want to reward yourself. So maybe not having it every night. But I'll tell you, ice cream, Yes.
Would you discuss the different signs that in heart attack with women and men, the difference? There's some symptoms within women.
There are, everyone's different. So you can say gender, but we're all unique. So women tend to present more with symptoms of dyspnea or shortness of breath, fatigue, rather than classic chest pain. So listen to your body. So if you are more sure with less exertion, or you're tired with less exertion, and remember, as we get older, that's going to happen, but it's out of proportion to what you really think. Then you should probably see your physician. And don't wait. Don't think it's going to go away. For most people, it's not going to go away. There was a woman who I just saw today. She was shoveling snow. She had a chest pain. She was shoveling snow. She thought it was just going to go away. Well, she had a heart attack 3 days later. And she's a nice lady too. So listen to your body. So they say, okay, this doesn't. Like if you have flu-like symptoms, get checked out. Maybe it is the flu, but maybe it's something else. So, most people have those classic symptoms. But usually when you're doing something, that you have it, and there's a pattern. And if you have those warning signs, then just say, I need to be seen right away. Because most times, the doctor's office, we can't see it until Thursday. They say, well, let me talk to the doctor. And then if I talk to someone on the phone, I say, I really need to see you right away. You should come to the emergency room and check you out there. So it's really just listening to your body. Because most people do know deep down inside that something's going on. And people get scared.
On that close topic, would you define angina?
Okay, so angina would be how I define angina is when you have a chest pain that's due to underlying coronary artery disease. people got angina, but they really don't have angina. So it'd be, like usually it's just a heavy, dull weight pressure in your chest when you're doing something, and then it goes away if you rest. But you have to have the diagnosis that you have underlying coronary artery disease. So it could be angina-like chest pain with the heavy pressure in your chest when you're doing stuff. That's angina. Does that answer the question?
So what is it when you're just laying down in bed and you get the same pain, or you're sitting there watching television, or you're driving your car and you get the same sensation of a dull, heavy ache that feels like an elephant sitting on you?
Well, I'd still get that checked out. I think that, it's just because it's not with activity. Sometimes, this is more common in women, sometimes you have what we call microvascular disease, where the epicardial blood vessels, the major blood vessels that we see in a heart cavitation are fine, but the smaller penetrating arterioles and capillaries, the flow of blood is dysregulated, so it's not going to the right area. And that can cause that type of symptom too. We call it kind of syndrome X because we don't know what causes it. There's a lot of active research going into that. Again, the treatment for that is exercise. So that's definitely something to get checked out with, and it could be something else too. It could be one side of an aneurysm. It could be a pulmonary embolism. It could be a lot of things that you probably want to get checked out. Yes.
Question about blood thinners. On TV, we have a constant stream of lawyer ads about Xarelto and other blood thinners. What are the dangers, benefits?
Okay, so for any anticoagulant or blood thinner, the benefits would be to reduce someone's chance of having a thromboembolic event, particularly a stroke. And these are potent drugs that do lower someone's risk for having a stroke. And most strokes due to atrial fibrillation are devastating, in that they really affect your life. So that's the benefit of the drug. The risk of the drug is that the risk of bleeding, not causing bleeding, but the risk of bleeding is higher. So you have to have a source of bleeding for these drugs to make the bleeding worse. They don't cause bleeding, because if they cause bleeding, then anyone who took it would be bleeding. So, but if you have a source of bleeding, whether it be from your GI tract or your urogenital tract or from your nose or from your lungs, or you just cut yourself, you're going to bleed more, because that's what they do. They inhibit clotting factors. So warfarin, this is the older one, inhibits 4 of them, whereas Xarelto and Eliquis inhibit factor 10, and then dabigatran or Pradaxa inhibits factor 2. But they're relatively, when I say safe, they do cause bleeding to be worse. And so what you have to do is you have to go over the risks and benefits of the drug. Really, because there is a risk if you have a bleeding from your GI tract, you're going to bleed more. I will say with the newer agents that their half-life is very short, so they get out of your body pretty quick. So the tincture of time usually is a cure. And most bleeding from the newer agents, the nuisance bleeding, means that you do have more bleeding from the GI tract, but it's not life-threatening bleeding. And the bleeding for intracellular bleeding is a lot less. So I think those ads are kind of really, they're false in the fact that they say they cause bleeding. It's really when physicians or healthcare get in trouble is when they either not using the drug appropriately for the wrong indication, or the dose of the drugs not dosed according to either their kidney function, or their age, or their weight. That's when because the dosing is really based upon those parameters. And then how we determine whether we recommend an antibiotic, we look at someone's risk. We call it CHADS-VAS risk score, and then we look at the HAS-BLED, the bleeding score. And unfortunately, as people get older, the risk of stroke gets higher, and the risk of bleeding gets higher too in these drugs. So you gotta, ultimately too, at least in my practice, I don't make that decision. I go over the risks and benefits, and then the person makes that decision. And they can always change. They go, well, I want to try it out, and then 2 years later, say, well, I don't want to do this anymore. And that, as long as they know that they're at risk of having a stroke, or they go on the drug, they have a risk of bleeding. So it's a good question because the drug's a target. Unfortunately, I have a family emergency I have to go to soon, so I can take a few more questions, but I have to go soon, I'm sorry. So, I think, yes.
Me again. If I were to carry on my person a, I don't wanna use like a drug, but a Coca-Cola or something, you know, I'm just using it as an example. What would I carry with me every day that would, just in case I started to get a pain, I'm just putting, it could be's, would be's, I got a pain. What would be an easy way to mitigate or help yourself
Cell
out?
phone to call 911.
Okay, well, that's fine, I mean,
No,
just,
yeah, I'm not kidding, because if you don't have the diagnosis of coronary artery disease, and you take nitroglycerin is gonna lower your blood pressure, you pass out, and you're treating something you don't know. Now, if you, it's different if you have an established diagnosis, say you've had an angioplasty stent, had bypass surgery, yeah, you could carry nitroglycerin, but if you not have that formal diagnosis, you could do more harm than good by taking nitroglycerin, because it's like throwing a dart in a dark room, I hope I hit the bullseye.
okay. Thank you.
You may get somebody else. So, at least unless I know exactly what I'm doing, I'm not gonna do that. So, I would carry a cell phone. Hey, I'm not doing so hot. Get here right away.
Do you look at your patients as having, I would assume most of your patients are over 60, say. Do you assume that they've done something wrong in their life to
No.
have a heart problem?
No.
Because if we were talking to a room of 20-year-olds,
No.
and everybody in that room did everything that you said, what percentage of them would still be your patient when they're in their 70s or 80s? I wonder. That's a magic question.
No one does. I mean, we all, you know, people who smoke, they didn't do anything wrong. They just, you know, the decision, I mean, for me, it's not a good decision. And for them, it was the right decision because they decided to do it. It's not a healthy decision. And in my opinion, it's the right decision, but in their position, it's not. But they try to encourage them to try to quit. But some people don't want to quit, some people do. If they don't want to quit, it's a dead issue. Because that affects my relationship with that person. Because they know it's bad for them. But nicotine is a very addictive drug. Fortunately, I've never tried a cigarette. But it's just unhealthy. It's not bad, it's just unhealthy. So I try to foster the relationship, try to encourage them. And you know, if you get that relationship, maybe one day say, maybe I'll try to quit. So it's really, it's that passion. We really do care. Because I'm not judgmental. I just want to help somebody out. So if they say you just don't want to do that, then you know, if it's an emergency, like if someone had a heart attack and they're in the hospital, I say, well, I don't think you have a choice, you have to go. But other things, so just try to, it's like in any relationship, you know, between spouses or you just try to foster that relationship for growth in a good way, mature as a person.
But my point was heart problems are mostly preventable, whereas cancer and other diseases are perceived to be not preventable.
Yeah, you can make a lot of inroads from any cardiovascular disease. And I'm always to get that, foster that relationship with that person that comes to see you. So that, you know, I really do care about you and let's try to make good decisions. Because a lot of times when, you know, behaviors are hard to change. But if you really show that you do care, then maybe that person say, well, maybe I can make an effort. And even just smoking like a half pack of cigarettes rather than a pack is better than that. So just losing. I tell people how realistic goals. Like, you want to lose weight, you lose 1 pound every 2 or 3 weeks. And then, you know, by the time the year ends, you're going to have lost probably 20 pounds. That's a lot of weight. I'm sorry. So
a number for the carbs that you can ingest in a day and cholesterol? I mean, what would be too many carbs?
Oh, carbohydrates? I'd have to look at you. I really don't know that. I think it's individualized. I mean, but what I try to avoid, like instead of having 2 rolls for dinner, have 1 roll. So I just simple things like that. Instead of having 2 slices of toast, have 1. Have half a baked potato or one. Things like that.
Thank you very much.
Thank you.
And then really, it's an honor to be here, it really is, it's really, I meant that, because we're a community, and, that's important, and it shows, because you came out,
I echo that. Thank you, everybody, for coming. We've got some refreshments here, if you would like to, before you go, and,
and I gotta go, my little brother's not doing so well.